Okay, we'll go ahead and get started. Lots of questions. Where to start? We have had several questions asking, this is regarding plagiocephaly, about craniosacral therapy. And is it effective? What's your take?
That's what I use.
Yes.
I have never had a patient find craniosacral therapy truly effective in correcting their plagiocephaly. To me, from just a pure physiologic standing, it doesn't make much sense. If it would, I think we'd probably get a lot more success, and like there wouldn't be a need for helmets if that was a true, effective, consistent treatment. So I don't recommend craniosacral for treating plagiocephaly.
Dr. Moen, someone's asking for more of an explanation of scoliosis in overweight adolescents. Mm-hmm. Do they have a higher incidence of scoliosis or just a bigger curve when they're finally diagnosed?
So we don't think that they have a larger incidence of scoliosis. It is just that it is more difficult to see and more difficult to measure, and so it's more likely to be missed. And so in that population where it's harder to see, they may be more skeletally mature, an earlier bloomer based on their, obviously, that they are just more likely to present at a time when their curve has already had a chance to get more meaningfully developed and is a larger curve at that time.
Several questions about what to tell the parent whose baby, quote, hates tummy time.
Oh, yes. Oh gosh, that's always very challenging. When I start with my patients, because I have a lot of patients that hate tummy time, I usually say, well, let's start small. And I love using, again, that, like, let's roll them in. I'll say I'll take 10 seconds of tummy time versus no tummy time. So we're going to start small. I'm building a contract with that baby. We're going to roll over. We're going to do a little bit of tummy time. Once I feel like they're getting, and parents are getting to that point where it's like we're melting, then we're going to roll on our side and try to calm down and kind of take a break. Let's catch our breath and kind of just introducing being familiar being in that position instead of working on total time. First we got to be okay being there before we can increase our total time. So starting small and increasing our frequency of attempts. I know a lot of parents are like, they hate it and then they're fussy and like by the end of the day, I just don't even want to try. So I'm like, when are they happy? And they're like, usually around 10 a.m. I'm like, then that's when we're going to work on it. Our goal being that we're doing it all day long, but let's start in that happier window. So I'd say starting in a happy window and start for really short bouts with the goal not being total time, just being there.
Yeah, there's a question about parents being told they can't do tummy time until the cord falls off. And I've gotten that too in my office from the hospital staff.
I don't know where that's coming from. Please do tummy time as soon as possible. I mean, there's a reason that when babies are born, they're placed on mama's chest. And so let's encourage that as much as frequently as possible. I think most babies that hate tummy time is because they didn't start it until they're 1 to 2 months later. And so, I mean, I don't enjoy exercise when I've taken my 1 to 2 months off.
No, I don't ever like to exercise. Dr. Moen, this is a good question. What is the relationship between leg length inequality and scoliosis?
So I think so there are folks who have a leg length inequality, which you can measure by when they're standing. You might feel that their pelvis is asymmetric. And now again, if somebody does have a curvature in their spine and their flank is asymmetric, it may look as though their pelvis is asymmetric as well. And sometimes both can be occurring. But we would expect that if you had a meaningful leg length difference, you would have an apparent scoliosis. So it would look like you had a curve in your spine, but it was relative to the leg lengths being different. And so we can assess that by trying to put a lift underneath what we think is the shorter leg and measuring the pelvis again when they're standing, and looking at the shoulders as well, and looking at the scoliometer or the inclinometer measurements with lift and without. Oftentimes we're making that more formal diagnosis when we're doing the scoliosis x-rays, because the scoliosis x-rays typically have the top of the pelvis as well, and sometimes you can see that the pelvis is asymmetric there. I will say that there is oftentimes where my assessment is going to be, there's a mild spinal curvature that may or may not be impacted by a mild leg length discrepancy, and so I'm talking, and so you can, I will use the lift. I will try to make a measurement of the legs either from the anterior superior iliac spine down to the medial malleolus, but sometimes that's easier to measure than others. You can go from belly button down to medial malleolus. Sometimes, if needed, you can get an X-ray of the legs, a scanogram or a standing alignment film. But I think that, or you can get a seated scoliosis X-ray, because that will level the pelvis. But most of the time, you can discern whether it's a meaningful leg length that's causing the problem, or really something less than half an inch. A discrepancy of the leg lengths of half inch or less is not likely to cause a significant scoliosis, and so for me, I'm looking at that spine meaningfully and watching that closely.
But just a couple of sort of how do you get things done questions. For example, the EOS X-ray, is there a long wait for that?
So I see Carlos in the audience, our nurse, and he helps. So I don't think there's a long wait for it. It is my understanding that they have a number of X-ray machines over at Children's. This is one of them. What we do is we write a prescription and put in an order to have them done. I do make sure that I tell the parents to let the radiology tech know that they were sent over there for EOS X-rays, because otherwise they may just flow through and go to the standard X-ray machine. It's my understanding that the cost is the same. And so we have, I think other than the potentially needing to go to another place to have the study done, I think that it has been a fairly user-friendly thing.
Okay. And one more question. I know you see scoliosis patients because I've seen you my own, but I know you don't do surgery.
Right, so I no longer do surgery. So when we've got curves that are approaching surgical range, or I think are going to get to surgical range, then we will make a referral to our friends, often at Children's, or friends down at Shriners. Children's has hired a couple of newer physicians who have spine specialty, Dr. Bauer in particular, who's really lovely.
So really in this area, it's Children's?
Yeah.
Okay. Oh my gosh, I got distracted. So a few questions about helmet therapy.
Yeah.
Can you just touch on when you feel like that's appropriate and sort of the course of treatment?
Absolutely. I kind of I had to leave out a few rabbit holes. So helmet therapy, typically what I recommend, I don't start a helmet until kids are rolling and sitting on their own, because then developmentally the helmet won't impact them. Recently, insurances are requiring at least 2 months of therapy before they will cover the helmet. So that is a really, really important thing to note, because we have a lot of families that will, especially our just flat back of the head brachycephaly kids, that come in because they tried to get a helmet and then they were like, well, you can't get a helmet until you've done 2 months of therapy. And so that can really delay their time of getting a helmet. So typically usually I have a kid get a helmet or evaluated for a helmet about 6 months old, because usually they're rolling and sitting by then. And then depending on their growth, we usually have a big growth spurt around 6-7 months. So if they can get in their helmet by 6.5, they are in a helmet typically about 12 weeks, but I have like had a couple kids recently that we capitalize on that growth, and we've been at like 8. And so it's effective to do. I do a lot of counsel with parents on helmets and should they do it, should they not do it. I always tell them I don't care if you do a helmet. I usually go to the moms and say, if you're gonna rub their head for the rest of their life and that's gonna bother you, I would do a helmet. And because after one, you can't really make much of a difference.
What about the recessed pillows? What do you think about those?
I don't recommend those. I have yet to find a magical positioning thing out there that you could put in, because, well, first of all, back to sleep, we don't want anything in that crib when they're sleeping. And so most of the positioners that are designed are for when kids are laying in bed. So that's step one of fun, like, don't use that. Secondly, they straight up just don't work. They become more of a headache for parents to, like, they kind of get fixated on it. I'm like, it's their baby sleeping, go to sleep. So yeah, there's unfortunately nothing on the market that really works.
A few questions about swaddling and
Yeah.
what's an appropriate swaddle, and then using mittens and all these things that we put on babies to
Absolutely.
help them sleep.
Also my favorite topics. First of all, the mittens, no thank you. Babies bring their hands together into their mouth, and that's nature's way, that's their nature's pacifier. That's how they learn to self-soothe. They're coming to midline. That's what we do when we're nervous. We come together. So that's like the first thing that I do when a baby comes in my office. I take those off, and parents are like, should they not wear them? I'm like, no. Swaddling, I know, and there's so many sleep things out there on the internet. And I understand how important sleep is, but everyone is teaching everyone to swaddle with their arms down because it puts a baby in a straitjacket, and the baby is like, I don't know what to do, I'll go to sleep. That has then, in turn, created this sleep consultant culture because none of these newborn babies have figured out how to self-soothe. And so once they're starting to roll, parents are like, we need to wean the swaddle. So they let their arms out and they stick them up, and they don't know what to do and how to find their midline. So I always encourage getting hands to midline with our swaddles. If you've got the power baby that's busting out, I'm like, at least do one hand up. If they've got a little preference, I'm going to do the opposite side than what they like. So that's kind of the biggest thing that I would recommend.
Dr. Moen, there's a question about the scoliometer.
Yes.
Let's see, I thought that when you take your scoliometer reading and multiply it by 3, that is a good estimate of the Cobb angle. Is that true?
It is not unreasonable. I mean, I think that the challenge is that the scoliometer reading is related to spinal curvature, but not in a linear fashion. Now, the reason that the cutoff for referring at 7 degrees was that is typically an X-ray finding of about 20 degrees. But again, you can have a large rib deformity with a scoliometer reading of 10 and no spinal curvature at all, and you could have a 30-degree curve in the lumbar spine that has a scoliometer reading of 3. So that's why it is a helpful management tool. It is not a specific diagnostic tool. And so I think that can be a hard one for the families to get their head around because they'll say, well, Dr. Jones said I had a 7-degree curve, and now we got an X-ray, and now you're saying it's 20. It went up 13 degrees, so being clear about that. But I think it is still likely, because 70% of adolescent idiopathic scoliosis is thoracic. The majority of curves are going to be in the upper region, so they are going to be associated with rib humps, and so that's a not unreasonable thing to think that, yes, I mean, that 7 degrees is likely to give you about 20 degrees on it.
And then a couple of questions on the role of chiropractic care in scoliosis.
Yeah, I mean, I guess that I would say that I'm not a chiropractor, and I don't know all that chiropractors learn and do. My best read of the literature is that I have not seen compelling literature that chiropractic manipulation can keep a curve from getting bigger or make a curve go away. And so if families are saying, I would like to try chiropractic manipulation, I would say, you can do what you feel is the right thing. I think we need to monitor it anyway. But I definitely have had a handful of kids that said, we're going to try this. They came back with really big curves. So I don't think that it alters the progression of scoliosis. I think in the setting of back pain, that might be a very different thing. But I usually try to tell parents that I don't see a contraindication. But I guess I will be clear to say I do not prescribe it.
Okay, last question is for Danielle. As you know, it's sometimes hard to get kids in to see a therapist. Several people have wondered, what would you recommend us as primary care docs telling the family to do until they get in to see you?
That's my favorite question. That's a great question. So I know a common thing that I often hear from my families is that they're first prescribed to turn their head while they're sleeping. Once a child has a preference, that's like a fruitless effort. Like, then you've got these moms that are exhausted and they're like, I don't know, we've got this other thing, and they keep turning their head, and they turn their head and they lay back down, and then the baby goes, cute mom, and turns back. So the thing that I like to do is, instead of just turning their head, alternate where you put that baby's head in the bassinet. So I've even had, like, I'm looking at a mom talking to her about it, and I can tell she's like exhausted. So I go grab a clothespin and put a sticker on it, and I go, you put it on this end on Monday, that end on Tuesday. And so that way you can alternate which end you're putting that baby. Just because your head is here in the bed doesn't mean the baby's head has to be here. Secondly, I would strongly encourage them to start doing some side play. What I typically recommend is that put them on the side opposite than what they like to turn to. You're not going to do any damage by having them, if like they do it wrong. Getting them just out of being on their back is going to be so helpful. And it's also going to get us going on that head shape, because that's one of the things that we prescribe is doing side play on the opposite side of the flat side. So side play and then alternating their ends of their bassinet.
Great. Thank you both. That was great.
Thank you.
So we'll take a break until 3:05.